Hello everyone, this is Fatima Ammar, and today I'll talk about a very important skill to have, which is interpretation of chest x-ray. So learning to interpret a chest x-ray is like learning a new language. Once you know the rules and you practice it, you will gain the skill. So the first slide talked about some historical information about chest radiography. And for the second slide, we need to understand that chest x-ray is not a routine test. We need to have a reason to order chest x-ray. For example, if here are some symptoms that we can order chest x-ray because of that. If the patient has bad or persistent cough, chest pain, chest injury, coughing up blood, fever or shortness of breath, or status post-fall. And why the chest x-ray is the most common modality to use in clinical practice? Basically for three reasons. The first one is chest x-ray is cheap and it has a low radiation and widely available. Like most of the hospitals have a machine to do a chest x-ray. So what we are looking for when we are ordering a chest x-ray. So here's some abnormality. When we are ordering a chest x-ray, we need to expect something. For example, we need to expect is it lung cancer, hypertension, pleural effusion. I'll go over all of that later, but here's some of the diseases that we can gain much information about using just a chest x-ray from. For example, if we do a chest x-ray, we can follow up with biopsy or with other scan, but chest x-ray, it's going to be essential step for all of these abnormalities. And here, for interpreting the chest x-ray, I'll go over a systemic approach to interpret a chest x-ray. But for now, first I'll talk about what is the views for the chest x-ray. First of all, we have anterior posterior view, or we have also a posterior anterior view, PA, and we have lateral, and sometimes they do a lateral decubitus. The most common or the preferred view to do is posterior anterior view, this one, the PA view, and we're gonna go why it's preferred to do it. First, all of this views based on what? ايش اللي خليني اقول انه هذا anterior posterior view ولا lateral ولا posterior anterior view؟ هذا كله determined by كيف البيشن يوقف، كيف وقفة البيشن تكون متعلقة بالديتكتور and the X-ray machine. For example, in this picture, a patient facing the detector and the patient give the back for the X-ray machine. لما يجي البيم يخرج من ال X-ray machine, gonna be like that. So the beam gonna penetrate the patient back first, then the detector gonna create a picture. This is called posterior anterior or PA. ليش؟ لأن البيم حق الشست حق ال X-ray machine penetrate the back first. Okay? هذه most preferred picture to gain, and we're gonna go why. We're gonna go about in details why this is the most preferred picture. Here another picture from the slide for the patient. Here the patient facing the detector, so the X-ray beam gonna come from here and gonna penetrate the back first. You're gonna get this picture. So we can do anterior posterior view when if we are in the ACU, the ACU patient gonna be most of the time lying down and like has many tubes, IV pools, and like many monitoring devices. So it's hard sometimes to move all of that and have the patient stand up. They're gonna bring a chest X-ray machine to the patient, and they're gonna put the detector behind the patient, and here gonna be the chest X-ray. The beam gonna penetrate the anterior chest first, then the posterior. Because of that, we call it anterior posterior view. And in this picture, we can see like that the patient has many devices to monitoring. So we're gonna go first, like we're gonna go first to here, like the gravity change from the AB view to PA view. For example, what is the difference between both of these views? The cardiac size, we're gonna assess if the cardiac size gonna be different or not, and هل العرض حق الميدياستاينم gonna be affected or not, the diaphragm position, and also meniscus of the pleural effusion, and the vascular shadow. Okay, so here in the anterior view, the heart appears larger. We're gonna go over this point and why the heart appears larger, and the mediastinum gonna be widened. The diaphragm are higher gonna be, and you can imagine why. Because like we are penetrating the anterior structure first, and the heart situated more anteriorly, so that's and the diaphragm, why it's gonna be like there is more anterior structure, liver and spleen and all of that gonna, or actually the liver and the stomach and all of that might interfere with the anterior posterior view. And here the pleural effusion, it's gonna layers posteriorly, and pulmonary vessel size, actually it's gonna be the same in the upper and lower field. So this is if you want to know what is different, what's gonna be different from anterior posterior or AP or PA view. And actually why the posterior anterior view, the cardiac solute gonna be smaller. If we have a X-ray machine and it has a beam, the beam will penetrate the back first, as we already said, and then the picture not gonna be magnified, gonna be magnified slightly. So if this is the size for the heart, it's gonna appear like this in the film, and we're gonna get this picture. Okay. However, in the AP view, we're gonna penetrate the heart first. Okay, it's mostly anterior. It's gonna be anterior compared to the PA view, and then by the time the beam is gonna appear in the film, it's gonna be increased and magnified. Okay, and that's like why it's gonna be this cardiac size gonna be enlarged in the AP view. So we're gonna back to this picture quickly. So here the cardiac size between the PA and AP, and so if we want to ask is this a PA or AP, we can know for sure that this is a PA. And if we want to know this AP and why, because like there is a clues, there is many tubes, but just by looking at the cardiac side, we can know like if it's a PA or AP. And we already, why do we have to know? So if we want to interpret a chest X-ray, إذا ما عرفنا إذا إحنا بهذه الصورة إذا PA or AP, لما نجي نحسب الكاردياك سايز or cardiac solute حيكون عندنا يعني ممكن we overestimate, like if it's a AP view for example, like here AP view, it's a large, ممكن نقول إنه هذا cardiomegaly and it's not cardiomegaly just because it's a AP view not PA view. It's important to know if it's AP view or PA view. Okay, and here just a picture for the lateral view, and here for the lateral decubitus position. Actually they do it to know if there is like an air in the peritoneum like space. If there is an air, it's the most like أكتر position حتبين لنا if there is an air in the peritoneum space. طيب دوبنا تكلمنا عن الفيو different views حقت الchest x-ray وقارنا between AP, PA and lateral, just we went over it quick. إيش three factors that determine if the chest x-ray gonna be bright or dark؟ أول حاجة density, thickness, time of exposure. يعني إيش هذا الكلام؟ أول حاجة يعني density. مثلا we know that if the structure is denser, it's gonna appear white, and if the structure has less density, it's gonna be black. What does mean? Like if we see this scheme, metal and pacemaker and joint replacement gonna appear really white as we see here. Off-white gonna be the bone, and as we see here, like we can see through the bone, so it's gonna be off-white. Sometimes they divide the gray to light gray and dark gray, but muscles, fat tissue, and the heart, all of that gonna appear like in the like the scheme of gray color. Like black, it's gonna appear air or lung. So what's appear, that's all based on the density of the structure itself. Thickness, for example, لو طلعنا هنا, here we can see that هنا أصلا في scan, بعدين بعد السكان في fat, بعدين بعد الفات we can see like there's a heart and a vertebrae, heart and a sternum and like many structure. So there is many structure for the X-ray beam to penetrate. The thickness can determine, like if there is a lot of structure, it's gonna be brighter. As we see here, like there is, for example, this bone, it's not white as this structure. And why? Because like here, just like scan, then the lung, then like there is not a lot of structure, not vertebrae and all of that. So thickness plays also important part in determining the darkness or brightness of the chest X-ray. Here important also a time of exposure. مثلا لو عندي let's say patient, and the patient facing the detector, and here the X-ray beam, and here another patient, for example X-ray beam. لو عرضنا البيشن هذا ل X-ray like has 2 seconds or less than that, an X-ray beam gonna penetrate the structure and draw it here, so it wouldn't have enough time to actually penetrate a lot of structure. It's gonna just give us like a shadow for the picture, so the picture gonna be brighter. لكن لو مثلا نقول أعطينا 30 سكند، هذا مو ممكن يصير، بس مثلا بس عشان for the sake to understand the time of exposure لchest X-ray وحطينا البيم كده، لو قلنا هذا الهارت، هذا الفرتبري، هذه all the structure، البيم حيجي كده، حيجي مدة أطول، حياخد وقت إنه مو بس penetrate the heart and all of that, also like more beams gonna appear, so it's gonna be darker. المهم في هذا الشيء بس إنه الشخص يعرف إنه كل ما زاد التايم كل ما البيكتشر كانت darker، كل ما قل التايم البيكتشر حتكون brighter. تمام؟ هذه 3 factors determine the brightness and darkness per chest x-ray. ليه مريت عليها؟ لأنه لما نيجي نعمل assessment for the quality for the chest x-ray أو حنعرف إذا البيكتشر كانت overexposed or not. ف it's important to understand this concept. تمام؟ هنا في rules. Actually I found it much easier. It's called ABC rules for reading chest x-ray. هذه rules has 7 steps ومرة سهل إنه الواحد يتذكرها علشان هي just alphabetical from A until G. So 1, 2, 3, 4, 5, 6, 7. تمام. أي chest x-ray you handle it, you need to assess all of that. في البداية حياخد وقت الموضوع, but once you assess many chest x-ray and follow these rules, it's gonna be quick. A stand for assessment of the quality. ليه أول شيء إحنا we assess the quality because ما في فايدة إنه يعني أعطي تشخيص من chest x-ray وهي الكواليتي حق الإكس-راي ما هي كويسة، نفس الكواليتي حق الصورة ما هي كويسة، فحيكون التشخيص ممكن يكون خاطئ عشان هذا الموضوع. تاني حاجة البون، وحنتكلم على الامبورتنت بون اللي احنا we need to assess the chest x-ray in the chest x-ray and we need to like know if it's like normal or not. The cardiac, C stands for cardiac. As we already took in the cardiology block or cardiovascular block about the chest x-ray and how to assess it in terms of the cardiac. And the diaphragm. Effusion, some people call it like everything else. E stands for everything else or effusion. I found it much better to say like effusion and then remember to assess also everything else, like if the patient has endotracheal tubes, ECG electrodes or pacemaker. And F stand for lung field, G for great vessels. تمام؟ كل هذه الأشياء أي chest x-ray you handle it, just go over it. Once you go over it, you're gonna know if it's like this chest x-ray has abnormality or not. تمام؟ So هذه each step and what we assess in it, we're gonna go over it, but this is just like the plan. أول حاجة التكنيكال assessment. الحين رجعنا للمحاضرة. ليه احنا قلنا all of this؟ علشان أول شيء technical assessment اللي هي هنا A assessment of quality. إيش إحنا لما نعمل technical assessment we need to assess inspiration and we need to assess the penetration, sometimes they call it also exposure and the rotation. كيف إحنا نعمل assessment ل all of this؟ أول خطوة technical evaluation. عادة لما ياخدوا chest x-ray ياخدوها during inspiration. تمام؟ فكيف أعرف إذا هو a good inspiration or poor? Basically by counting the reps. هنا عندي صورة أوضح. مثلا we need to count from like if had a diaphragm, count the reps. Usually it's gonna be from 9 to 11 reps. هذا normal from the PA view. تمام؟ إذا كانت الريبس أقل من هذا الرينج فهذا حيكون poor inspiration. So we need to know this علشان في بعض ال diseases depend on the inspiration. تمام؟ ف basically هنا كيف عدوا الريبس؟ عدوها هنا في دي الصورة انعدت بالعكس، بس في دي الصورة it's okay, like this is posterior. We can count ribs as we see here. الأصفر يدل على posterior, الred يدل على anterior, and basically if you can see like this, the anterior, this the second, and here the third, and here the fourth, like they count the posterior and anterior in the same picture. So يصير أول خطوة من الخطوات اللي احنا assessing the technical assessment of the quality is inspiration. Okay, تمام. هنا بس بيعطينا مثال إنه ال hyper expansion of the lung في COPD disease كيف حيكون، وهنا poor inspiration. تمام. تاني حاجة ال penetration or exposure. هنا زي ما قلنا قبل كده، هنا under exposed، يعني شايفين قد ايه الصورة is bright، يعني التايم علشان ياخدوا ال chest x-ray كان ممكن يكون ما أخذت البيم ما أخذ وقت كفاية علشان يعمل لي الصورة حقت chest x-ray، فهذا under exposed. هنا over exposed. ليش؟ It's so dark that we cannot actually see some of the structure, so it's very important to assess هذه يسموها exposure. في penetration it's important to assess like can we see the spinous process, can we see the vertebrae, can we see like all of this structure. It's important to see the diaphragm, all of that. مثلا هذه الصورة we cannot see actually, like I cannot see the vertebrae here, so here assessment of the quality, this is not a good picture to even like say a diagnosis from it, because the penetration is not that good. And here another example of underexposure of the picture and overexposure. تمام. ثالث حاجة في ال assessment of the quality الروتيشن. إذا أني بناخد chest x-ray هل البيشنت rotated، هل الصورة أصلا مأخودة كويس ولا لا. مثلا if we see this picture كيف نعرف الروتيشن؟ لازم نطل clavicle. Here actual medial part of the clavicle. إذا جينا نشوف medial part of the clavicle مع spinous process الدستن المفروض تكون تقريبا متساوية. هنا شايفين الدستن كيف هنا في راحة clavicle كده، هذا يدل إن patient actually rotate once they when they took the picture. تمام. ليه هذا مهم؟ ليه مهم أصلا نحن نعرف إذا patient rotated or not؟ إذا تلاحظوا هنا هذا أثر لي على إيش؟ الكاردياك solute. We cannot say it like it's here. It might not, the patient might not like even has a cardiomegaly, but عشان الصورة مأخوذة بشكل rotated اللنج فيلد كله أتغير وما صار أقدر أعطي تشخيص كويس. أو إذا البيشنت ما يقدر مثلا عنده some disease that prevent the patient from take the picture like in a proper position, in this case at least we know that the patient is rotate before we give a diagnosis, and we can expect that the cardiac size gonna be not accurately estimated. تمام. يصير حاليا اتكلمنا على أول خطوة which is assessment of the quality. تمام. اتكلمنا عن rotation, inspiration and exposure penetration. يصير هذه أول خطوة لما نيجي نشوف chest x-ray. I'll back to the slides. So identification of normal airways and lung. Here, like we need to know the trachea. It's usually here. We need to know the bifurcation. We need to know like the airways of the lung to assess like the normal structure. So basically this picture توضح الستركشر النورمال لايك للأيرويز and lungs. وهذه bronchiogram. I remember that the doctor said no one do it right now, but if you want to see just the trachea and you want to see the right main bronchus and left main bronchus and all of that, you can see it. Here also, like this is a picture showing like after coronary artery bypass graft. Basically here a catheter and it's entered left subclavian vein. كيف عرفنا هذه كل information? I just added here a picture for like where do we expect to see some structure in the normal chest x-ray, and if you compare it to this one, you're gonna see like a little tube or metallic, and this appear the place for the catheter. Here another picture, like just appear the sternal wires and all of that. And here the doctor mentioned also the rules that we already say about it, A, B, C, D, E, F, G, and each one like what we are assessing from each, what each letter stand for and what we need to look for it. By that we finished the first part. I just want to go over this. I'll leave this to you to read it because I don't want to overwhelm you with many information, but usually we ask ourselves for the second step about the bones, the bone fracture lesion, and for the third step the cardiac, and for the diaphragm, is it curved or not? If the diaphragm not curved, it might caused by COPD disease, or we need to know why. تمام. And for the effusion, for the costophrenic angle, is it sharp or not? If it's not sharp and it's blunt, we need to know why. For the lung field, does the lung has 3 loops, the right one? Does the left lung has 2 loops or not? And we can assess all of that by looking to the picture. For the great vessels, we can assess the aorta and pulmonary vessel. تمام. So by that we finish the first part, which is the normal chest x-ray. For the abnormal chest x-ray, I found it much better to categorize the diseases in this way, but I try to do it related to the lecture, so I do it in this way. مثلا نقدر نقول is the disease is airspace disease or not, interstitial disease or not, pulmonary nodule or masses or not, disease related to pleura, disease related to mediastinum, or disease of the chest wall. هذا I found this one أشمل. بس الليكتشر كيف احنا ماشيين في الليكتشر، ماشيين بالابنورمال chest x-ray. أول شيء في الهارت، mediastinum, alveolar and lung, pleura, diaphragm, soft tissue and bone. هذه كل واحدة فيهم we have abnormality in it, and we're gonna go over it right now. So first, for the heart, for example, here we need to assess the heart size and the cardiac solute. For example, here chest x-ray can show us that the patient has cardiomegaly, as we see here. But if we follow up with CT, we can say that this is not a cardiomegaly. This is because pericardial effusion. تمام. So it's important to know that not all cardiomegaly is caused by like heart failure. It's important to know that chest x-ray, if we suspect another disease, it's very good to follow up with another scan also. here like زي ما تكلمنا على في cardiology block, we say that the chest X-ray finding in heart failure can be cardiomegaly, prominent upper lobe blood vessel. يعني هذا الكلام يعني basically الفيسلز اللي في الأبر فيسل حيصير لها dilation، وهي المفروض تكون يعني الحجم حقها مو dilated، أو ما تكون حجمها أكبر من الفيسلز اللي داون. تمام. ف pulmonary edema هذه third sign and curly B lines pleural effusion. هذه 5 signs we can by it know if the patient has heart failure or not. Not necessary to have all the sign in the if the patient has like heart failure. Here some of the like here the normal vascularity كيف كان، بعدين كيف صار لما صار عند البيشنت pulmonary venous hypertension, pulmonary vascular redistribution صار. And what we mean by redistribution, basically that the vessel enlarged and the size for the vessel change, and here become interstitial edema and then alveolar edema. تمام. الكيرلي بي, I don't know if you can see it or not, I'm just gonna draw it again. So this is the curly B lines. If you see the curly B line, that might indicate a heart failure or congestive heart failure. Usually if you see curly B line with cardiomegaly, it's gonna be congestive heart failure most of the time, but it's all of that based on the patient history and physical examination also. And here left ventricular aneurysm. كيف نعرف إذا هذا left ventricular aneurysm ولا لا؟ Basically, if you see enlargement of the left heart border زي هذا enlargement, and we see classification, هذا classical finding left ventricular aneurysm. أو هذا ممكن يدل إنه patient already has a previous myocardial infarction. So if we read the history for the patient, and based on the history we read that the patient has already previous myocardial infarction, and the chest X-ray, as we see, there is an enlargement in the left heart border, and we can see like calcification. If you see the calcification also, it's brighter. That's, we can say like this is a left ventricular aneurysm. تمام. تاني حاجة من abnormalities اللي هي mediastinum. We can divide it to anterior, middle, and posterior. And the doctor said this is a very important slide. So basically, we need to know إيش most common reason for the like mediastinum mass. It's gonna be lymphoma in adults. تمام. وهذه أحد الأسباب الثانية. I think it's straightforward, like if you read it, it's gonna be easier. For the mediastinum abnormality, like we can have a mass in the mediastinum. For example, if we see mass at the center, and this mass has well-defined border, and we can see the vessel through it, so most likely this is gonna be either lymphoma, thymoma, thymoma, or thyroid goiter, actually a huge thyroid goiter that's going inferiorly, or aortic aneurysm. Most of the time it's gonna be هذه الأسباب لها, and based on the patient lab result and physical examination and history, we can know which one is this. And لما نطالع في lateral view, usually anterior and posterior mediastinum gonna be like darker, and here we see it brighter. So this is not normal. This indicates a mass in the mediastinum. تمام. And here anterior mediastinum mass. We need to get a biopsy to know which tumor, but the doctor said that this is a germ cell tumor. Here's some like if we got any of this picture, تمام, اللي فوق, and we got that the patient has night sweat and the patient is losing weight and palpable neck lymph nodes, على طول it's a Hodgkin's lymphoma. إذا جاتنا واحدة من هذه الصور مع هذا ال patient history على طول حنقول it's a Hodgkin's lymphoma. تمام. For the aortic aneurysm, basically إذا شفنا large aorta وشفنا الtrachea صار لها deviated, as we see in this picture. I think you can see that the trachea deviated, and here some median sternomy wires, as you see here. So هذا indicated aortic aneurysm. This is just finding, بس المهم عندنا إنه هو الأيورتا صار له enlargement، وكمان مو بس arch, it's also لين descending aorta مع deviated trachea حنقول إنه هذا basically aortic aneurysm. إذا قادرين هنا تشوفوا إنه كيف صار للتراكيا deviated to the left side. We'll go here. Yeah, if you can see it. So it's a little wide, but like we can see that the trachea is not in the normal position. تمام. هذه CT scan علشان توضح برضو الأيورتيك aneurysm. So hilar enlargement. So this is the third abnormality. If we see a bilateral opacity of the lung, bilateral opacity of the lung يعني هذا الكلام. Basically إذا بنشوف الpulmonary obfuscation حنشوف إنه هو إيش أصلاً هو decrease in gas to soft tissue ratio due to pathological process. For example, يعني الريشيو بين الاير والsoft tissue gonna change. عشان كده احنا بتطلع لنا الcolors بتصير زي كده whiter. This can cause because either airspace disease or linear or nodule, or they divided to airspace, linear or nodule obfuscation. Many reasons behind it, but I'm not just gonna go over it. I'll stick in the lecture slides. So here we can see that bilateral opacity, if you see, like here bilateral opacity, it's not a normal. We can at least distinguish that this is not a normal X-ray. تمام. بس إذا عرفنا هذا الشيء وعرفنا إنه patient has a joint pain and arrhythmia, not nausea, so we can know that this is sarcoidosis. تمام. إيش هو sarcoidosis? Basically growth of inflammatory cells, granulomas in any part of the body, والmost common place اللي هي يصير لها growth في اللung and lymph nodes. تمام. عشان كده احنا بنشوفها في chest x-ray. هذه تاني picture. So we can see like there is a hilar enlargement, multiple nodules, and mastectomy. So all of that, like we can say the hilar enlargement, and multiple nodules, we can also see it. And mastectomy, because we can see that this is not normal, so we can say the diagnosis is a renal history. مع picture هنقول it's a metastatic breast cancer with lymphogenic carcinomatosis. The doctor say this diagnose، بس المهم انه الواحد يعرف انه it's a metastatic breast cancer. تمام. ثالث abnormality في الهيلر position or halar enlargement. we can هنا هنقول it's abnormal halar position. تمام. most likely if you see that the patient has left halar malignancy treated with radiotherapy والهيلر صار له disposition or تغير مكانه، هذا because of radiation fibrosis syndrome. هذا side effect من الراديوثيرابي. so البيشنت عنده كان malignancy وكان بياخد radiotherapy، هذه واحدة من السايد effect للراديوثيرابي انه يصير له radiation fibrosis syndrome. تمام. for the lung abnormality we need to know that like we need to assess the lung field of view and all of that. إذا جاتكم صورة زي كده try to see like the 7 steps that we talked about it already, and بعد ما تشوف ال 7 steps like شوفوا اللي إيش ال abnormal في البيكتشر. compare the left to the right. we can at least distinguish that this is not normal because you can see like this is a whiter and it shouldn't be like this. وإذا عرفنا من الهيستوري حق البيشنت has a high temperature or productive cough، هذه to indicated مع picture like this على طول pneumonia. لأنه اللي بيصير هنا إنه air space، هذا واحدة من air space disease، وهنا يسموها هذه الساين يسموها air bronchiogram and obesity compared to the left side. طيب تمام. هذه الصورة لو جينا نقولها هنعرف انه في abnormality وانه هذه على طول pneumonia. مع actually it's more important to know the history. مع الصورة هذه على طول pneumonia، لأنه لو جاتنا صورة زي كده مثلا، هذه الصورة it's unilateral obesity. تمام. وفيها في النص إذا شايفين هذا ال dark spot، هذه low intensity، هذه على طول مع إذا البيشنت like has a history of intravenous drug and high fever، على طول هنقول septic impulse. okay as we see here. طيب إذا البيشنت ما نقول لنا إنه البيشنت عنده fever، إيش ممكن يكون differential diagnosis؟ ممكن نقول إنه البيشنت عنده squamous cell carcinoma، هذا أول differential. ممكن نقول إن البيشنت عنده TB or fungal infection. تمام. يصير هنا مرة important or key word إنه البيشنت عنده fever. تمام. هذا basically compared between like mass and infiltrate. so أول ما تشوفوا like a mass and this mass is well defined and you can draw a line زي ما احنا دوبنا سوينا line like around it، على طول هذا classical finding for lung cancer، إلا لو كان في another differential or a history تاني. infiltrate or airspace disease الclassical finding حقها أول ما تشوفوها مع patient history it's most likely gonna be pneumonia. تمام. هذه بعض الأسئلة اللي لازم نسألها لنفسنا. so إذا شفنا nodules في chest x-ray, is it a single or multiple? Is it a classified or non-classified. So is it an old or new? Is it a stable or change? تمام. زي أول هنا كيس عندنا، هذا patient عنده mass or multiple نقدر نقول nodule and it's well defined. على طول metastasis. Well, you can like draw a line and it's well defined. It's a multiple. This is a very bad tumor, and we can say that this is a metastatic disease or metastasis. تمام. لو كانت dense فيها calcification زي هذا picture, like you can see it in the chest X-ray. بعدين هذه CT، سووا CT. تمام. هي single وهي dense calcified nodule sorry. وهي old and stable. على طول it's a TB. تمام. يصير هذه أول single dense calcified nodule وهي old stable على طول equal TB. تمام. كيف عرفنا هي stable or not؟ شفنا السكان اللي صارت 2003 وهذا السكان صارت 2000 و 2 years عدت والنفس الحجم ما تغير فهي stable. تمام. هنا lupus fissure. Okay, so for this one you can lupus fissure basically زي ما قبل كم صورة تكلمنا إنه إذا ما كان قايل لنا إنه هي fever وإحنا عندنا يعني lesion here, so one of the differential diagnosis إنه حتكون squamous cell lung carcinoma. تمام. خامس abnormality اللي هي pleural diseases. تمام. كيف نعرف pleural diseases؟ أول شيء no lung marking. شايفين lung marking فين هنا وفين هنا؟ طيب ما احنا شايفين lung marking. تاني شيء decreased in the edge volume. If you can like see it or not, there's a decrease in the edge volume. So this is على طول ما نقدر نقول trauma to the chest pneumothorax. تمام. Attention pneumothorax, like if we can see here like the air pushing the lungs and deviated the trachea. إذا قادرين تشوفوا قد إيه اللنج صارت the whole lung is collapsed. هذا emergency as we already know, and this is tension pneumothorax. تمام. هنا we can see like the pleural effusion. هذا could be like pus fluid or blood, like X-ray show us that there is a pleural effusion. بس إيش هو ممكن يكون بالضبط we need to follow up with the patient more with another test. تمام. هنا large left pleural effusion. شايفين قد صار في elevation. والhemi diaphragm is obscured and heart border also we cannot see it. We order a CT to see like and you can see all the pleural effusion here. تمام. هنا unilateral thickening. تمام. في شيء عندنا اسمه pleural effusion وفي عندنا thickening. لو هنا صار عندنا thickening of the pleura if you can see. وصار عندنا multiple pleural paste زي ما هنا تشوفوا، هذه كلها يسموها multiple pleural paste. وصار عندنا decrease in lung volume زي ما احنا شايفين هنا، وكمان increase in thickening of the mediastinum pleura زي كده. هذه كلها مع الهيستوري is a key. like أول ما تشوفوا إنه البيشن has asbestosis exposure so على طول mesothelioma. تمام. إيش يعني mesothelioma؟ It's a malignant tumor caused by inhaled asbestosis fibers. تمام. على طول نقول هذا الدياغنوز. هنا حنعرف إنه هو البيشنت جانا بكرونيك mild shortness of breath، والبيشنت هو retired وكان exposed already ل asbestosis or asbestosis. اوكي، هذه الساين اللي احنا شايفينها هنا نسميها calcified pleural plaque. تمام، الساين calcified pleural plaque هي ايش يعني؟ هي area of fibrous thickening pleural. ممكن يكون عندنا differential diagnosis، ف we need to know the history for the patient. a differential ممكن تكون إذا patient عنده صار له treated for hemothorax، like متى نشوف ال calcified pleural plaque؟ حنشوفها لو مثلا البيشنت صار عنده treated hemothorax TB or histoplasmosis زي هذه كلها الأشياء ال differential diagnosis. We can also see the same like sign for the calcified pleural plaque. So it's important to know, it's very important to know the history. Okay, and here another picture also for the diaphragmatic. So here basically this is very easy. If you see like the diaphragm, we can see like there is an air under the diaphragm. على طول هذا pneumo, we can see the air and peritoneum like in the peritoneum space, so it's an air under the diaphragm. And for this one, left lobe pneumonia, and we can see like the left lower lobe collapsed هنا صار لنا. تمام، نقدر حطيناها تحت الدايفرام علشان احنا صار لنا في انه هي في الليفت لور لوب. تمام، عشان كده احنا حطيناها تحت الدايفراماتيك. فبس it's another picture, you can see it. For the seventh abnormality is the soft tissue. Already we talked a little bit about it, the mastectomy. لا يصير لها mistaken مع ال air space disease، لأنه أول so assist the like the diaphragm. Remember when we say like the 7 steps, A, B, C, D, E, F, and G. These indicate the diaphragm, so we need to assess the diaphragm. لما نشوف هنا diaphragm والmarking, like we can like know that this is mastectomy, because also the shadowing for the breast. So it's very important to assess everything. For the bones, most likely it's gonna be like a fracture, or like if there is a lesion. For this picture, we can see like here a fracture, if you can see it. I'm just gonna, so here we can see the fracture. So, or we can say like multiple rib fracture. And the second picture indicate like old rib fracture. كيف نعرف إنه هو old or هو new? Basically, you can see like it's the different and like how the rib is angling and if it's healing or not. تمام, we can distinguish that. And this picture basically is talked about the anatomy for the vessel, and this is like pulmonary angiogram, and they used to use it in the old days to diagnose PE, but not anymore. Like for the nuclear medicine, VQ scan, it's like nowadays it's used a lot in that, and if there is a mismatch between the perfusion and ventilation, it can indicate that the patient has PE. And also here we can see like this is a CT for the chest with contrast. If there is a lack in the contrast in some of the vessel, we can say that this is a thrombus. And here some anatomy for the aortic arch vessels. Thank you, and I hope that I would وضحت أشياء و simplify it more. If you have any question, please don't hesitate to contact me. Thanks.